the topic today that I have been given is in hospital initiation of ARNIs in post-acute decompensated heart failure but stabilized patients. These are my disclaimers. So, Abid Amin Saab gave a great talk, or I think it laid a very good foundation for my talk and makes my job pretty easy. So, just Abid Amin Saab told us that every time these patients are getting hospitalized, and he gave us a few pointers as to what makes them, these patients, more prone to hospitalization. One of the things that makes it an issue for us as cardiologists, and especially when we're dealing with patients who have heart failure, we know, and the patients realize that as well, that it's a chronic condition. It's not something like an acute MI where we fix an artery, patients go home, we see them every 3 months and they are stable. These patients, once they get admitted for heart failure, we know it's a sign of impending doom. We know every time these guys are getting admitted, their myocardium is getting damaged. They are not going home with the same amount of LV function that they came in with, and this obviously has implications in terms of how they're going to do. Every time these patients come in with decompensation, their future, the prognosis is bleak. Every time these patients go home in a worse NYHA state than they came in with, we know for a fact that they are looking at an early mortality as compared to somebody who is stable in NYHA 1 and 2 and is essentially out of the hospital. Heart failure, just like pretty much everywhere else in the world, for Pakistan as well, I think I can take out even 65, maybe in Pakistan we can call it 60 or even 55, is probably one of the most common causes of hospitalization in our population. And 44% of these patients who get admitted with heart failure at least once, they get readmitted within a year at least. And then the problem is not just getting admitted, and problem is not just the fact that once they go home they're going to come back and they are going to have an early death. The problem is cost as well. In Pakistan, where we live in a cost-constrained environment, that's a major issue. 1 day or 2 days in a major private sector hospital has a lot of implications on your on the financial aspects of a family. So all these things need to be considered when we are talking about therapy, and when if somebody tells us that this particular tablet is expensive, we need to compare it to the cost of hospitalization when we are trying to convince them to a bit more expensive therapy. What we know is that almost 25% of patients who get admitted to a hospital with heart failure, they get readmitted within a month. So just imagine as somebody who stayed in the hospital for 8 to 10 days, they spent about 8 to 10 lakh already, and they're back in with you in like 3 weeks. And we know for a fact that this time, their hospitalization might be even longer. This time, once they get home, they will be worse, and the chances of them coming back is even higher than what it was when they left the last time. So all these implications need to be in our mind when we are sending them home, and their discharge therapy should be carefully monitored to make sure that we are doing everything within our capacity to give them the best chance of not coming back to the hospital. So this is just data from US, 271 hospitals, and what they found was that every time somebody got admitted, the arrow is not showing, but every time somebody got admitted, they looked at what medicines they were on, and obviously, once somebody gets readmitted, this raises alarm bells and everybody thinks about it, and then the proportion of patients who went home on proper therapy was much higher than when they came in on. So this sort of gives us an idea that probably the first time that these patients went home, they were not properly treated. Only 44% were on an ACE. Beta blocker was there in less than half of these patients, which are essential meds. So if you're sending somebody home with heart failure, without a beta blocker, without an ACE inhibitor, you're doing injustice to this patient cohort. So obviously the main topic of this talk is the new molecule, which is ARNI. We have all looked at the molecule, so I won't spend much time on it. We'll go to the clinical implications. What it shows is this, that the ARNIs come in combination with valsartan. They are bound together, and this binding has its own impact. These two molecules in combination not only work on the sympathetic nervous system, but also work on the RAS system. And between the two of them, they would improve various vascular as well as heart failure outcomes. So paradigm HF already mentioned, I won't spend too much time on it. Here what we look at is ARNIs being compared to an ACE inhibitor, which is enalapril. In this case, the patients, about 8,000 of these patients were looked at, and what we found when these patients were treated with maximum doses of these two pretty essential therapies, there was a, as compared to enalapril, there was a 20% relative risk reduction in mortality when these patients were put on an ARB. And remember, this mortality benefit is on top of them taking all other essential heart failure medications, which are all, including everything which was in vogue at that time, except probably gliflozins. Everything else was being given to these patients. And enalapril, which is an ACE inhibitor, already has shown pretty significant impact on mortality, and this benefit is on top of it. So again, it shows it was superior. The numbers needed to treat were pretty astonishing, that you only need to treat 21 patients to decrease the risk of heart failure, hospitalization, or cardiovascular death. Remember, when we are talking about millions of patients, there is a huge room for improvement in terms of not only saving a lot of cost on the national health system, but also for patients' personal pocket. And a lot of times we see a lot of young patients who have had an MI, who are coming to us with an EF of 35%, and these are mainly the sole breadwinners of a family as well. So these are very significant cost implications, especially for our society. So in terms of paradigm HF, we saw a 38% relative risk reduction in 30-day readmission. This was not the primary endpoint. This was looked at by a secondary adjudication committee, which found that in 30 days, when we know that 25% of these patients are going to be readmitted, almost you can save 1 in 3 of these patients from getting readmitted if you are sending them home on an ARNI instead of an ACE inhibitor. So this led to this idea of transition study, which is a small study that they did as a target. And what they did was that they started these patients in hospital once they were stabilized in hospital, and they were started on these medications as pre-discharge, and then half the group was started on the same medication after being discharged. So this failed to actually achieve significance, but there was a signal that patients who were started on these ARNIs showed a better outcome in terms of all cause mortality and heart failure rehospitalizations once they were started as during the in-hospital stay after stabilizing them. So this led to the idea of Pioneer HF, where almost 880 patients were randomized. The first 8 weeks for double-blind, double-dummy, where what it essentially means was nobody actually knew what they were on. Either they were on enalapril or they were on ARNI for 8 weeks, and after 8 weeks, everybody was put on an ARNI. And what they found was that patients who were started on enalapril, there was a significant reduction in BNP levels when they were on ARNI. So just one thing for people who are like me, who are not that well adept in understanding the biochemical mechanics of a drug. So ARNI or sacubitril essentially is a neprilysin inhibitor, which essentially stops the degradation of ANP and BNP. So if you look at the actual mechanism, it actually increases the level of BNP in the blood, and it makes the BNP or the ANP, which is being released by the body, work to increase natriuresis. So a drug which actually increases BNP at the molecular level is actually decreasing the level of BNP, which means that this is an increased level of BNP which is now coming down physiologically. So it's making your own hormones which are being released by the body to address this issue of heart failure or fluid overload. It's just making it work over time to help the patient diurese better. So what we see is that once, no matter whether if you have not put these patients during their in-hospital stay on enalapril, even if whatever point in time you do change it to an ARNI, you achieve similar long-term outcomes. In this case, it was 12 months. So what were the secondary endpoints? They looked at the other biomarkers. We know all these patients who come in with heart failure, they do have a mild trope leak, which sort of remains at a plateau. And what we saw that patients who were on an ARNI had a reduction in their troponin levels, their ST2 levels, and then their BNP levels were the major finding of the study. So overall, what we know is that patients who were started on an ARNI early showed a much bigger or much higher reduction in cardiovascular death or rehospitalization. This is just the executive summary of the same thing. So based on these trials, ACC and AHA have changed their recent guidelines, which just came out last year, which were mentioned by Professor Abid Saab as well, that they are still recommending ARNI, ACE, and ARB, all three as the first-line therapy. However, in patients who have chronic symptomatic heart failure, NYHA 2 or 3, remember in NYHA 4, there is no drug which has really shown a mortality benefit. In NYHA 4, you're just working with diuretics, like just to improve patients' breathing status and dobutamine and all these things, because they are all admitted in fluid overload. So we are talking about 2, 3, and probably 1s. These are the patients where you can make the difference. So ARNI is recommended as de novo treatment in hospitalized patients with acute heart failure before discharge. So not really recommended in the middle of an acute decompensated episode, but once they're stabilized, probably we need to think ARNI first rather than an ACE inhibitor when we are planning to send them home. In Pakistani environment, as Professor Abid Saab very nicely wrote, and me and Dr. Bandesha were talking about it, the same thing, that in Pakistan there is an issue of follow-up. Patients don't always come back to you. Physicians in OPD are always reluctant starting, even for blood pressure patients. I see most patients being started on a beta blocker or a Norvasc or amlodipine or something, rather than a combination with an ARB, because we don't want the hassle of monitoring their creatinine and stuff over a long time, despite the fact that we know what the guidelines are. So in hospital, I think initiation gives you that room to monitor at least for the subsequent 24 hours what sort of an impact on kidney function these drugs are going to have. Thank you.